we've got the presentation up, so I'm going to pass it back to Dr. Karkar.
Thank you so much, Neil. Much appreciated. And thanks everyone for your patience and for, attending this talk so late in the day. So today I'll be talking to you all about the evaluation and treatment of epilepsy in individuals with chromosome 18 conditions. This is an updated, revised presentation from a similar one that I gave over our summer conference. So some of you may have heard a version of this presentation before. Ready for the next slide? So this is an outline of my presentation. I will be starting out with some definitions of seizures and epilepsy. Then I'll talk about epilepsy in the context of chromosome 18. I will spend some time on talking about how to recognize seizures. I will talk about the evaluation process for seizures and epilepsy with a neurologist. I will talk about what to expect at a first visit with the neurologist. I'll then proceed to talk about some testing for epilepsy and different treatment options in terms of medications and surgical treatments when medications don't completely control seizures. Next. So definitions of seizures and epilepsy. A seizure is a sudden burst of abnormal electrical activity in the brain. One could think of it as the brain equivalent of a heart rhythm problem. So just like a person could have like a skipped beat of the heart, similarly or analogously with the brain, one could have this excessive or abnormal electrical activity. If it involves one part of the brain, we call that a partial or a focal seizure. If this abnormal electrical activity involves the entire brain, then we refer to that as a generalized seizure. And these definitions rely heavily on EEG. A focal seizure has onset from one focal point or one region of the brain, whereas a generalized seizure starts out from all over the brain, as we would see on an EEG. Next. So there are different types of seizures. Like I mentioned, there are focal seizures versus generalized seizures. And even within focal seizures, there are subdivisions. So there are seizures with intact awareness. We refer to them as focal with intact awareness. The old terminology for this type of seizure is simple partial seizure. But since 2017, we are officially using this terminology with focal replacing partial. So focal with intact awareness. There are also seizures where there's impaired awareness. The person himself or herself would report losing time. A family member or anyone observing the episode may comment that the person is not responding normally during the seizure or is completely unresponsive. In the old terminology, we used to refer to this type of seizure as complex partial seizure, but it really means the same thing as focal with impaired awareness seizure. Next, please. And just like there are focal and partial seizures, there are generalized seizures. Again, these are seizures that start all over the brain at once. And within this category of generalized seizures, there are different divisions. There are the tonic-clonic seizures, also known as grand mal seizures. There are drop seizures of different types, either with loss of tone, in which case we would refer to it as an atonic seizure, or with increased tone, in which case we would refer to that as a tonic seizure. There are absence seizures, which are characterized by a very brief loss of responsiveness or awareness, typically lasting just a few seconds. There are myoclonic seizures, which consist of a sudden arrhythmic or non-rhythmic jerk of the body, the limbs, or both. And there are also other less common generalized seizure types, such as sometimes a hybrid of one of the two that I mentioned, like a myoclonic absence seizure, which combines elements of an absence seizure with elements of an myoclonic seizure, so myoclonic absence. Next, please. Now, what is the definition of epilepsy? Well, epilepsy means that a person has had 2 or more seizures, as long as those 2 are not on the same day. For example, if a person has 1 seizure this month and then in 3 months has another seizure, we are not talking about an isolated single seizure, but instead we are talking about a seizure disorder, also known as epilepsy. So epilepsy and seizure disorder mean the same thing. It means that the person is at risk for having seizures, as long as these are unprovoked seizures. By unprovoked, I mean there's no provoking medical condition such as low blood sugar or very low sodium level that could result in anyone experiencing a seizure. So that's what I mean by unprovoked, that there is no medical condition that's actually provoking a seizure, such as the 2 examples I gave, but there are others, such as a brain infection, acute trauma to the brain, etc. Next. Now, let's talk about epilepsy in the context of chromosome 18 conditions. Now, there is a higher prevalence of epilepsy in the context of chromosome 18 conditions. Based on a seizure survey that the Clinical Research Center performed in 2012, based on the responses that we received at that time, we estimated a prevalence of anywhere from 0 to as high as 59%. By comparison, even though epilepsy is one of the more common neurological conditions, only about 1% of the general population develops epilepsy during one's lifetime. So as you could see, when you compare 10% or 15% or 59%, to 1%, we're talking about an increased prevalence. Only 18P plus, which was a very small sample in that survey, did not report seizures. All of the other conditions reported seizures. Next. Now, there is this particular gene on chromosome 18Q, the TCF4 gene, which is causative of Pitt-Hopkins syndrome. This is a syndrome that comprises not just epilepsy of the generalized type, but also other symptoms, including symptoms of autism. It is an example of what we refer to as a developmental and epileptic encephalopathy. What does that mean? The gene itself causes both a predisposition to seizures, which is an epileptic encephalopathy, in other words, but also the gene itself causes some of the other non-seizure symptoms, such as autism and intellectual impairment. So this is an example of, like I mentioned, a developmental and epileptic encephalopathy. Next. Now, we are in the process of updating our survey. We, starting this summer, we sent out emails requesting from our families to fill out and complete a survey. So this new survey is expanding on the survey of 2012 by adding additional questions, not just focusing on epilepsy, but also asking about other related symptoms, such as mood and other psychiatric symptoms that may be present, cognitive symptoms. These are what we refer to as comorbidities, meaning problems that are co-occurring with the epilepsy, meaning happening together with the epilepsy. So by doing the survey again, about 12 years later, we're also looking for changes over time. Next, please. So like I mentioned, emails have been sent to ask for the completion of the updated seizure survey. And thank you so much for everyone who completed the survey. Those in attendance who have not had a chance to complete it, we would really appreciate your participation, even if there is no history of seizures or epilepsy. Having a survey completed by everyone would allow us to have a more accurate estimate of the prevalence of seizures and epilepsy in our families. Next. All right, so let's talk about how to recognize seizures. With increased prevalence of seizures, it's important to know how to recognize seizure-like events or seizures when they do occur. Now, some seizures are obvious, most everyone would be able to recognize a convulsive, also known as tonic-clonic or grand mal seizure. However, other seizure types would be more challenging to recognize. Next. For example, absent seizures are more difficult to recognize, compared to, say, convulsive seizures. When a person has an absent seizure, it's unless one is looking at the EEG of the brainwaves at the moment of the seizure, which obviously one doesn't have, even in a doctor's office most of the time. It's hard to tell, if this is a seizure or some other seizure-like events, such as reduced attention, etc. Similarly, myoclonic seizures could be difficult to distinguish from physiological jerks. Like as we drift to sleep, it's very common for a person to twitch a little bit. And most of the time, this is not due to a seizure. And like I mentioned, myoclonic seizures could be sometimes difficult to identify and distinguish from physiologic type, similar events. Next. So these are some features that I'll be listing on this slide that could help identify and distinguish seizures from other, non-seizure events. Seizures tend to be stereotyped. Having said that, other behaviors that are not seizures can also be stereotypes. So that by itself, wouldn't be a very specific distinguishing feature. Seizures also tend to be brief. So if someone has an event that's lasting tens of minutes or hours, it's statistically very unlikely to be a seizure. Seizures usually range anywhere from a few seconds to up to a few minutes, but rarely longer than that. When a person is having a seizure, it's difficult to get their attention. So if you're able to get someone's attention during a seizure-like episode, like if you're thinking someone might be having an absence, then it's likely not a seizure. On the other hand, if a person is having a seizure, it's hard to, it's not possible to snap them out of it, during the seizure itself. And there is a certain pattern for the motor activity that would allow a person, who's trained to recognize seizures to identify them. If a person has a tonic seizure or an atonic seizure or a clonic seizure, these are, neurologists are trained to recognize these different symptoms and signs of a seizure. Some of the motor manifestations are even more challenging than what I just listed. With focal seizures, there could be automatisms. A person could be doing some lip smacking, and that is sometimes a seizure symptom. It can look like they are chewing something when in fact, they are having seizure symptoms or signs of a seizure. Tongue biting also tends to be very helpful as a specific motor manifestation or complication of a seizure. Next. And, I find it very helpful as a neurologist, as a doctor, to review home video recordings of events. So if in doubt, make a video recording and share it with your doctor in the clinic. And that could be very helpful. Sometimes more helpful than an EEG. And I'll explain why once we get to the EEGs. So let's talk about getting evaluated for seizures and epilepsy. The first step would be to get assessed by a neurologist. If a person is younger than 18, one would be seeing a pediatric neurologist. If older than 18, it's an adult neurologist. I myself happen to be an adult neurologist. Most of the patients I see are, I sometimes will see a 16 or 17-year-old, but the 99% of my patients are older than 18. Now, what is the difference between a neurologist and an epileptologist? Now, I also happen to be an epileptologist. An epileptologist is a subspecialist in epilepsy and seizures. This is additional training, typically over 2 years of fellowship, which follows, the first 4 years of neurology training to become more subspecialized in epilepsy and seizures. Now, does one have to consult with an epileptologist right away? Well, not necessarily. Reasons to see an epileptologist would be if working with a general neurologist does not completely control the seizures. We refer to, so unfortunately, about a third of individuals with epilepsy, we're not able to completely control the seizures with medications, which means that the remaining 2/3 of patients can achieve full control with medications. So if one is in that 1/3 group, the 30% group, then consulting with an epileptologist, could be helpful to discuss additional treatment options and a more subspecialized approach to the problem. And an epileptologist, would be the specialist to see if one is considering a pre-surgical evaluation if medications are not able to completely control the seizures. Next. Okay, so how to find a neurologist? Usually the primary care physician would make a referral. One could get recommendations from friends, family, online reviews could be helpful. One's local school of medicine, the Department of Neurology, would have, a neurologist to choose from. Next. So the first visit with the neurologist, there will be lots of questions that are being asked, but also be ready to ask questions of your own, of course. The doctor will ask you questions about the onset of seizures, the frequency of seizures, the types of seizures. Like I mentioned, there are focal seizures, generalized seizures, and they have different symptoms. Any history of past testing and treatments. The neurologist will likely do some testing to include ordering an EEG and also very likely ordering an imaging study such as a CT, CAT scan of the brain, and or an MRI of the brain. Next. So there's also going to be a discussion of treatment options. And this is a relationship, that's built over time with the neurologist. The first visit is usually an intro visit, but subsequent visits, will continue the process of, testing and treatment discussions. At each visit, one would arrange for a follow-up visit. Make sure that, you have the contact information of the clinic in terms of telephone, but also the secure patient portal. At our clinic here, we refer to that as My Chart, which and other medical record systems will have a similar procedure to communicate, in written form. Some of the clinics, and ours included, could have a mid-level provider. By that, I mean either a nurse practitioner or a physician assistant. Now, this could be actually a great asset, as a mid-level provider could fill in for the doctor when they are not available, or could also support the doctor in reducing the wait times to care. Now, as long as this is not the only provider, so alternating visits is acceptable, but you also want to see your neurologist as well. Next. Let's talk about testing. So we usually start with a routine EEG. By routine, I mean not a long-term EEG. So a routine EEG would be done over 30 minutes or 1 or 2 hours. And the goal here, most of the time, we're not expecting to record seizures, but the goal is to record the in-between seizure signs of epilepsy. And I refer to what I'm talking about are the sharp waves of epilepsy, and I'll give examples of that in the next slides. Now, if the EEG is concordant with the history, then one doesn't need a long-term EEG. So this is an example of an EEG. So this is an EEG of a patient who presented with events that are suggestive of focal seizures. What I mean by that is, a history of 30 seconds of initially feeling an aura of déjà vu. Then after this initial phase of the aura, the patient loses awareness. A loved one observes the patient having, lip smacking or repetitive movements of their hands lasting for a minute or two. During this time, the person is unresponsive. So here in the clinic, I'm thinking this is suggestive of a seizure, highly suggestive, as a matter of fact. But when I do this EEG and I see this abnormality in the middle of the page, the sharp wave, then I'm putting 2 and 2 together, and this confirms the diagnosis beyond any doubt. So I don't know if you could see, but there is this sharp wave in the middle of the page. And this is the so-called interictal epileptiform discharge. We refer to it sometimes as the sharp wave of epilepsy. This is not a seizure, but this is a brief electrical event. You could think of it as a fragment of a seizure or a seizure trigger, or the first a seizure that's about to start but then doesn't take off. Next slide. And this is another EEG of a patient with a sharp wave of epilepsy, except that it's involving the entire brain. As you could see, the sharp wave is not limited to one region of the brain. And by the way, each line corresponds to a different part of the brain. So this is an EEG that covers the left frontal lobe, the left parietal lobe, the left occipital lobe, the right frontocentral region, the left temporal lobe, the right temporal lobe. So each line is an electrode that records from a different brain region. And as you could see, there is this sharpness in the middle of the page. And this is an example of a sharp wave of epilepsy of the generalized type. So someone with a history that is suggestive of generalized epilepsy, if we get an EEG and it has this kind of abnormality, it would provide confirmation to a diagnosis of generalized epilepsy. Next.
Dr. Karkar, just before you move on to the next one, we've got about a 5-minute window left, just as an idea.
No, thank you so much. That's really helpful.
Okay, thank you.
Yeah, and I should be able to wrap up by then. Now, this is an EEG from a patient with Pitt-Hopkins syndrome, also showing those generalized sharp waves of epilepsy, and the brain waves are characteristically slower than expected in the context of this developmental and epileptic encephalopathy, like I mentioned before. Next slide. So let's talk about other testing. I mentioned that there's also the option of doing a 1 to 5 day EEG. Now, when is this necessary? Reasons to do it would be if the initial routine EEG does not provide the confirmation that is sought. If there is remaining uncertainty about the diagnosis, but also there are cases when we have a clear diagnosis, but but the patient is still having seizures, and there is an interest in performing a pre-surgical evaluation, in which case getting a long-term EEG over a few days to record the actual seizures would be the first step to localize the seizures and explore surgical options. Next slide. This long-term EEG could either be performed at home, in which case we call that an ambulatory EEG, or in the hospital setting. And there are advantages and disadvantages to each. At the hospital, we're able to reduce and stop the medications because it's a controlled, safe environment, whereas at home, one advantage is that it's one's natural environment, and sometimes seizures are more likely to occur in that more natural environment. Next slide. This is an example of an absence seizure that's recorded in the context of an epilepsy monitoring unit. And as you could see, there's this abrupt onset of this rhythmic activity that correlates with when the child stopped responding. And it only lasted about 10 seconds. Next slide. And this is the continuation of the seizure. And this is where the seizure stopped in the middle of the page. Next slide. We already, touched on that, how video recording of a home event could be quite helpful to the neurologist. Next slide. All right, let's talk about other testing, including imaging studies. Brain imaging would be essential to perform, especially if the cause of the epilepsy is unknown. The CT CAT scan of the brain would be easier to perform, yet it's a lower resolution study. The MRI is a higher resolution study, but it's also more challenging in that the person would need to be really still and cooperate. And sometimes it does require the use of anesthesia, either conscious sedation or generalized anesthesia. If we have a clear cause of the epilepsy, such as a genetic cause, and the EEG shows consistent findings, the CT may be sufficient. One doesn't necessarily need to obtain an MRI. But MRI would certainly be needed if there is a need to launch a pre-surgical evaluation. Next slide. Let's end on talking about concepts of treatment. Treatment is usually not initiated after a single seizure. However, if a seizure disorder, epilepsy, in other words, unfolds, treatment is indicated. And there are different medication options that are available. Next slide. And here, in the next few slides, I have some of the medications. Keppra is perhaps the most commonly prescribed, also known as levetiracetam. It has lots of advantages in the sense that it has an intravenous IV form. It can be used, therefore, for acute emergencies, including treatment of seizures that wouldn't stop, also known as status epilepticus. However, it does have psychiatric side effects. And these tend to be dose dependent. Lamotrigine is an excellent medication. It's well tolerated generally. Unfortunately, it doesn't have an IV form. And unfortunately, also, it does take a long time to start, about 8 weeks, because if one were to start that too quickly, there could be an allergic reaction. There's a higher risk of an allergic reaction that could develop. Next slide. And here in the next slides, I do mention some other medications. Oxcarbazepine is another commonly used medication with, pros and cons. It could sometimes result in hyponatremia, low sodium levels, so blood work monitoring would be needed. And there are some other less commonly used medications, zonisamide, topiramate. In the interest of time, I won't talk about those. Next slide. And there is cannabidiol, which is one of the newer medications. It's derived from cannabis. It's an FDA-approved medication, actually, under the brand name Epidiolex. It can be quite helpful in the context of an epileptic encephalopathy, such as Lennox-Gastaut syndrome. But it's not FDA-approved for focal epilepsy. Next slide. And in the interest of time, I'll skip over to the next slide. Just a brief word on blood work that we use. Medications generally require monitoring to make sure that there's no negative impact on the liver, the kidneys. And also we check blood work to monitor medication levels and ensure that they are therapeutic. Next slide. Next slide. And I will end on talking about some surgical treatments. If medications, like I mentioned, about 30% of individuals with epilepsy were not able to completely control them, there are surgical options, and of two different types. There is resection surgery, which is reserved for focal epilepsy when the seizures come from one location only, and that location would be safe, would be feasible to perform surgery in. And there are these neurostimulation devices, such as the vagus nerve stimulator. There's another device that's called the responsive neurostimulator. And there's also a device that's called the deep brain stimulator, which stimulates deep in the brain in an area called the thalamus. And these are neurostimulation devices of different types where resection isn't feasible because it is focal epilepsy, but it's in an area that we refer to as eloquent, meaning it's not safe to do surgery on, or the type of epilepsy is generalized, meaning coming from all over the brain, in which case one wouldn't be able to cure it by doing a limited regional treatment. Next slide. Next slide. So I already gave an overview of these different neurostimulation devices. Next slide. Next slide. Next slide. Next slide. There's also the dietary therapy, the ketogenic diet, by cutting out carbs in the diet. It's known to be effective, but it's also a very harsh diet to adhere to. Next slide. And I would like to end with some conclusions. There's a higher prevalence of seizures and epilepsy in chromosome 18 conditions. Evaluation with neurology includes testing to include EEG, CT, and/or MRI. If treatment is needed, there are many good options with different pros and cons. And there are also surgical options, like I discussed, resection, and different types of neurostimulation. And I will go ahead and end my presentation at this time. Thank you all so much for your attention.
Well, thank you so much indeed. And we apologize that we've asked you to fit such a vast subject in such a short amount of time. And you've done an amazing job of giving a wonderful overview with where our families might be able to go. We do have a number of questions that are kind of coming in. And perhaps what we might be able to do, again, in the interest of time, is to be able to kind of pass those on and be able to perhaps kind of deal with those like that. So thank you very much indeed, Dr. Karkar, for being here tonight and being such an important part, a new part of the clinical research centers. So we're going to have